welcome to the deep dive. Today, we're getting right into what is, I think we can agree, the single biggest challenge in medical retina, geographic atrophy,
Yeah,
GA.
absolutely. For so long, it's just been this relentless march towards central vision loss for our patients with dry AMD.
And our options have been, well, let's be honest, pretty much observation and frustration.
It's still the #1 cause of central blindness for the elderly in the developed world. We're talking about a total permanent wipeout of the RPE, the photoreceptors, everything in that area. The need is just stark.
It is. So our mission today is to do a really rigorous analysis of the 18-month findings from the GATHER1 trial. We're going to be zeroing in on Avacincaptad Pegol, or ACP.
A targeted C5 inhibitor.
Exactly. So we're focusing on some really sharp data today, and it reveals both, the promise and some of the real complexities of using complement inhibition to fight this disease.
And this is essential stuff for any clinician managing AMD patients. GATHER1 isn't just data, it's really a fundamental validation of the complement cascade as a primary target.
Okay, so let's start right there. Let's unpack that foundation.
Yeah.
Why the complement system? I mean, we've known inflammation is involved for a while, but what makes this pathway the focus?
Well, the evidence is just overwhelming at this point. GA pathology it's intrinsically linked to the complement cascade just going haywire.
Overactivation.
Total overactivation. I mean, you look at drusen, they're just loaded with complement components. C3, C5b9, you name it. And then there's the genetics. Patients with certain genes, like complement factor H polymorphisms, have a dramatically higher risk.
So it's not just an association, it's a driving mechanism.
It's the engine of the disease.
But ACP is really specific.
Right.
It's not a broad anti-inflammatory, it's an inhibitor of C5 cleavage. Why that specific target? Why not say C3, which is further upstream?
And that is the crucial nuance here, because while you want to stop the fire, the complement system isn't just a villain. It's also essential for, ocular homeostasis. Things generated by C3 activity, C3b, IC3b, they are vital for clearing out the garbage. Apoptotic cells, immune complexes. You need that system working.
So if you hit C3 too broadly, you might shut down the cleanup crew.
Exactly. And some preclinical work even suggests that could be detrimental. You could even accelerate the degeneration. The whole strategy with a C5 inhibitor like ACP is to be more surgical.
Okay.
You inhibit C5, and you restrict the downstream effects to just the inflammatory C5a and, of course, the ultimate weapon, the membrane attack complex, or MSC.
So you're stopping the MSC attack while hopefully preserving the good C3 stuff.
You're trying to put out the fire without turning off the building's entire plumbing system. That's the rationale.
That selectivity seems, foundational then. Let's shift to the trial itself, GATHER1. For our colleagues listening, the mechanics, the inclusion criteria, that's all essential context.
It was a very well-designed trial. International, prospective, randomized, double-masked, sham-controlled.
The gold standard.
The gold standard. They enrolled patients 50 and older with pretty good vision, ECVA between 20/25 and 23/20. But the key was the lesion itself.
What about it?
The GA lesion had to be non-center point involving at the start.
Okay, so the fovea was spared at baseline.
Spared but threatened. It had to be within 1.5 millimeters of the foveal center, and the lesion size was capped between 2.5 and 17.5 square millimeters.
So they were specifically enrolling patients who were, right on the cusp. The disease was active, it was heading for the center, but it wasn't there yet.
Precisely. It's the perfect window to see if you can slow things down and delay that foveal involvement.
And the dosing. It was split into 2 parts.
Right. Part 1 tested a 1 milligram and a 2 milligram dose against sham. Then Part 2 brought in a 4 milligram dose and compared the 2, the 4, and sham in a larger group.
And this was all monthly intravitreal injections for 18 months. That is a huge treatment burden.
A profound commitment for the patient and the clinic. And the primary measurement was tracking that GA lesion growth over the 18 months using fundus autofluorescence, FAF.
Okay, this brings us to a methodological point that for this audience, we absolutely cannot just gloss over the statistics. They used a square root transformation. Why is that so vital? Why not just measure the raw area?
This is such a key point for interpreting the data correctly, GA growth isn't linear.
Right.
The growth rate depends heavily on how big the lesion is to begin with. A big fire spreads faster than a small one. A large lesion grows faster. So if you just track the raw area, you're introducing a huge bias.
So the treatment effect gets muddled with the baseline size.
Exactly. The square root transformation essentially normalizes that. It linearizes the growth rate. It allows you to see the true biological effect of the drug, taking that inherent growth velocity of bigger lesions out of the equation.
So it ensures we're actually comparing apples to apples.
That's it. It validates the data.
Okay, that makes sense. So let's get to the results. The 18-month efficacy data. This is where we see that sustained benefit, right? The gap between treatment and sham keeps widening.
It does, and that's the good news. The efficacy didn't just hold, it continued to accumulate. So if we look at that key metric, the mean GA growth with the square root transformation, the 2 milligram group reduced progression by 28.1% compared to sham.
28%. I mean, in a disease that had nothing, that is highly significant. And the 4 milligram group.
Very, very similar. It showed a 30.0% reduction, so a difference of just under 2% between the two doses. It really suggests you're hitting a therapeutic plateau around that 2 milligram dose.
Now let's talk about what the patient feels. Vision. Visual acuity. We know BCVA is a tricky endpoint in GA trials. What did that data show at 18 months?
Well, as you'd expect in GA, everyone's vision declined a bit over 18 months, even with treatment.
Unfortunately, yeah.
But the ACP groups did numerically better. There was a difference favoring the 2 milligram group by about 2.4 letters and the 4 milligram group by about 2.8 letters compared to sham.
So 2 to 3 letters. And I have to ask, is that really a clinically meaningful benefit for the patient at that point?
That is the right question. And at 18 months, probably not. The patient might not notice that small difference, especially since these were non-foveal eyes to begin with. But you have to think long term.
It's about the trajectory.
Exactly. The true benefit of that 28 to 30% reduction is cumulative. The catastrophic vision loss, that happens when the lesion hits the fovea. And that often happens after the 18-month mark.
So the goal is delay. You're slowing the atrophy train down by almost a third, which could, in theory, push out that devastating event by years.
That's the win. Delay is the win.
It seems like ACP is providing a powerful complement to our traditional approaches just by buying the patient more time. Let's pivot to safety, because that's always the other side of the coin with a new monthly injection. How did the drug hold up over 18 months?
Generally, it was well tolerated. Most of the AEs were what you'd expect from the injection procedure itself. A little hemorrhage, some discomfort.
Sure.
And crucially, no cases of endophthalmitis, which is great. The investigators didn't feel any of the ocular or systemic AEs were directly related to the study drug itself.
But there were a few serious events noted.
There were, yes, a few isolated ones. 1.5% of the 2 milligram group had an optic ischemic neuropathy, and 1.2% in the 4 milligram group had a retinal detachment. We also saw one mild case of vitritis, some inflammation, in the 2 milligram group, but it resolved on its own.
Okay, let's get to the elephant in the room. The biggest safety signal, the thing that really complicates this whole picture, macular neovascularization, MNV.
This is the clinical paradox. We're slowing down the atrophy, but the rate of conversion to wet AMD was, well, significantly higher in the treatment arms.
How much higher?
In the 2 milligram group, the MNV conversion rate was 11.9%.
In the 4 milligram?
Even higher, 15.7%.
15.7. And compare that to the sham controls,
which were down around 2.5%. So you're looking at a 5 to 6-fold increase in risk.
Wow. That is the number that every retina specialist has to really grapple with. And I should note, when these eyes developed MNV, they were exited from the study, right?
They were. Which means our long-term data on the trajectory of these specific treatment-related MNVs is a bit limited, at least from this paper.
So what's the thinking here? Why would blocking inflammation, which should stabilize the retina, paradoxically increase neovascularization? Let's walk through the main hypotheses.
This is where it gets really interesting biologically. The first idea is, well, it's almost a consequence of the drug actually working.
How so?
By slowing atrophy, you're keeping more RPE cells and other retinal cells alive, healthier cells that would have otherwise died. And what do those cells produce?
VEGF-A.
Exactly. So more surviving cells could mean more VEGF production, which just tips the balance toward neovascularization. Keep the tissue alive, you keep the engine for NV alive too.
Okay, that's one. What's the second hypothesis? Something about macrophages.
Right, macrophage switching. So in an inflamed eye, you have these destructive M1 macrophages. But if you inhibit C3a and C5a, which are powerful drivers of that inflammation, you might be shifting them to the pro-angiogenic M2 phenotype.
And those M2s are known to promote vessel growth.
They support tissue remodeling and neovascularization, so you're changing the cellular environment to one that's more favorable for vessel growth.
And the third hypothesis looks at the choriocapillaris itself.
It does. This one involves a gene called RGCC. It's highly expressed in the choriocapillaris, and when complement is activated, RGCC can trigger apoptosis cell death in those endothelial cells.
Part of the atrophic process.
Likely. So by blocking complement with ACP, you might be preventing that cell death, keeping the choriocapillaris vasculature more intact, which is, a prerequisite for MNV to develop.
It's an incredibly complex picture. You're in this trade-off, slowing atrophy but maybe encouraging vessel growth.
Oh.
So with all that, let's talk about the next step, the GATHER2 trial. Why did they ultimately land on the 2 milligram dose?
It was a very pragmatic safety-first decision. The efficacy difference between the 2 milligram and 4 milligram doses was tiny, right? Less than 2%.
Right.
But the 4 milligram dose had a higher injection volume and was associated with numerically higher adverse events, including that higher MNV rate. So with basically the same efficacy, the better safety profile of the 2 milligram dose made it the logical choice.
So what's the takeaway from all this 18-month data? It really seems to support C5 inhibition as a real, sustained way to treat GA. But it comes with a major new management challenge.
Absolutely. The benefit is delaying that devastating move into the fovea, but you have to weigh that against the need for very rigorous monitoring for this drug-related neovascularization.
Which leaves us with a final, I think, provocative thought for everyone listening. And that's about the nature of this MNV itself. We always think of MNV as bad, and exudative MNV certainly is. But there's this idea that non-exudative type 1 MNV has sometimes been associated with slower GA progression.
That's a fascinating concept. The idea that the neovascularization is almost a rescue attempt, trying to bring a better blood supply to the struggling outer retina.
Exactly. So if ACP is keeping the choriocapillaris from dying off, and that leads to this MNV, could that new vasculature sometimes be protective? It's a bizarre trade-off. A possible protective effect versus the undeniable risk of a future exudative conversion.
It's an area that we're going to need a lot more data on, for sure. Understanding the natural history of these specific MNVs is the next critical step.
And on that note, that's it for this deep dive into the 18-month findings of the GATHER1 trial. We've covered the rationale, the methods, the efficacy, and of course that critical MNV safety puzzle.
A lot to think about.
A whole lot. A link to the study is in the podcast description so you can pore over all those tables and figures yourself. We encourage you to follow the podcast for more in-depth analyses like this one. And if you found this discussion helpful for your practice, please take a moment to leave a 5-star rating. Till next time, keep those fundus cameras ready.